بشكر حضراتكم على الحضور وبشكر شركة AstraZeneca give me the chance to be with you. My talk this afternoon about the smart approach in management of bronchial asthma. What do physicians do with the variability of the disease? You know, bronchial asthma is a variable disease. Usually, we used to use the controllers, either inhaled corticosteroids or combination of ICS and LABA as a maintenance controller therapy, and the rapidly short-acting beta agonist as a reliever. But we know that asthma is a chronic inflammatory process, and when there is an exacerbation, a more exacerbation, that means there is increase in the inflammatory process. And the logic to cope with this is to give anti-inflammatory, not a reliever. Usually, we give the reliever, much more reliever, and then we give the controller either the higher doses of ICS or even the oral steroids very late. This is not in Egypt or in the Arab countries only, but also in Europe, according to the EAR study, Asthma Insight and Reality. Even the asthmatic patient there depend much more on the reliever, even in the severe form of asthma, and they do not take the controllers as recommended. We know that asthma is a variable disease, and the variability is there, not from month to month or day to day, even from a moment to moment. And in spite of that, we depend on fixing dose of the maintenance therapy, the controller, the anti-inflammatory in a variable disease. So we have periods of under-treatment with excessive use of rescue medication, oral steroids, and also we have periods of over-treatment because the disease is controlled, and we using this over-treatment, unnecessary drug intake, and unnecessary drug cost. So the challenges of this disease all over the world, according to the TRACK study, the reality asthma control, over-reliance of the asthmatic patient on the rescue medication, the reliever, and at the same time, the suboptimal control, they do not take the controllers as recommended. This is due to the poor adherence to maintenance therapy, and all of that is due to lack of physician education to this patient, and maybe to the complexity of treatment, because usually we advise the patient to take the controllers as a maintenance therapy twice a day, and he should also have a reliever to take it whenever he or she needs. The most important point is that asthma, there is early sign of worsening of asthma, and the build-up of the signs and the severity of signs, this is a mirror image of build-up of inflammation. Here is the start of the signs of warning, and it usually takes up to 5 days to reach the worst form of symptoms. In this period, the patient should have to intervene very early, not with the reliever, but with the anti-inflammatory, the controller, to prevent the inflammation to go up and more, and to reach the worst stage, and at that time, he or she mostly will be in need of oral steroids. The patient should have to take the window of opportunity to intervene as early as possible when the signs of asthma became worse with the controller. This is the hypothesis of the Symbicort SMART. It is the abbreviation of Symbicort as a single medication for both maintenance and reliever. That means the patient will take the regular daily maintenance dose of Symbicort plus an additional dose whenever there is exacerbation. Usually, the patient used to take the reliever, but we are sure that whenever there is exacerbation, he should, beside the reliever, take the anti-inflammatory, which is Symbicort. So, at that time, and because, as you know, Symbicort contains a bronchodilator beside the inhaled corticosteroid, the patient is not in need to take short-acting medication. That means the patient will have one medicine for controller as a maintenance therapy besides a reliever. So the traditional therapy was to use a maintenance therapy, ICS, or combination of ICS and LABA, whatever the combination, and the reliever when needed. But with Symbicort SMART, that's only one medicine taking at the maintenance therapy and the reliever. And the cornerstone in this Symbicort SMART approach is to treat the underlying inflammation with anti-inflammatory in every inhalation. And as you know, the components of this Symbicort, the long-acting formoterol, which will act on the relaxation of the smooth muscle, reducing neutrophil and edema, and at the same time the ICS budesonide, which is rapidly acting within 30 minutes on the vasoconstriction within 2 hours, increasing the beta receptor function, reducing eosinophil, improve mortality and quality of life. And this goes with the recommendation of the GINA guidelines that SMART approach help the patient adjusting their controller therapy at the sign of worsening symptom. As early as possible, whenever they feel worsening of the symptom, they give anti-inflammatory so to cut the story from the beginning. Symbicort SMART, endorsed by GINA, reducing the exacerbation, improving asthma control, and at a relatively low dose of treatment. And for all of this, GINA give that evidence A. Is this SMART approach or SMART concept only present with Symbicort, and is it safe with higher doses of this ICS and LABA used at the maintenance plus as the reliever? What about the safety, efficacy and safety? Regarding efficacy, because it's recommended to give the maintenance dose, as you know, once morning, once evening, and in between when needed, but not more than 8 times, the total 8 times. Comparing 8 doses of Symbicort 160 4.5 and 8 doses of salbutamol, the bronchodilator effect and improvement FEV1 is the same as early from the 3rd minute, and it goes up to 3 hours. Regarding the safety, as you know, both the short-acting and long-acting, if taken in higher doses, the major side effect is the hypokalemia. Hypokalemia here is much more with salbutamol compared with Symbicort. This is with 8 doses, the maximum. Comparing Symbicort with the other combination, we know the ICS and LABA, and this is the fluticasone and salmeterol, the seretide, Symbicort, either one inhalation or two inhalation from the concentration 164.5. The improvement, and if you want, the bronchodilator effect is within 3 minutes. Because as you know, formoterol, besides being long-acting, it is rapidly acting bronchodilator as salbutamol. While salmeterol, which is the component of LABA in seretide, it's not rapidly acting, so it cannot be used in the approach or the hypothesis of the SMART. Regarding the studies, I will not give you the results of all these studies. I'm just giving you the results quickly of 3 studies. We all believe that for maintenance therapy in the moderate, severe, very severe asthma, we use combination of long-acting beta agonist with ICS. We know this, and this is the recommendation of the GINA guidelines. The difference with the new hypothesis, the reliever, either to use as a reliever, as we used before, the rapidly acting, short-acting beta-2 agonist, or long-acting beta agonist, or to use combination of long-acting beta agonist with the ICS. We know, of course, that ICS is not bronchodilator, but it is anti-inflammatory, and you will see the difference in the result of this study. This is 12 months double-blind study, 3 arms, in each arm more than 1,100 patients. The maintenance and the controller is the Symbicort, 164.5 morning and evening, and the difference here in the reliever, short-acting Bricanyl, long-acting formoterol, and here combination of long-acting with the ICS. This is the SMART approach. Difference is very clear here that combination budesonide and formoterol, when needed, beside the maintenance, will prevent the exacerbation. And if you compare this with the Bricanyl, the short-acting, this is highly significant. If you compare it with the long-acting, the formoterol, it is significant. So what is the difference between this arm and this arm? The difference in the reliever in that arm, the blue one, the reliever here is the long-acting, the formoterol, while here in the red arm, with much less exacerbation, is addition of the budesonide, the corticosteroid, to formoterol. Also, in the results, there is reduction of both the day and night symptoms when they use the Symbicort as the reliever, the SMART, compared by using the long-acting, the Oxys or formoterol, or the short-acting, the Bricanyl. This is the efficacy. What about the safety? Comparing the side effects due to the beta agonist, palpitation and tremors, they are comparable. Also side effects from the ICS, hoarseness and oral candidiasis, also comparable. The next 2 studies comparing using the maintenance Symbicort with seretide. 3 arms again. In each arm it is 6 months double-blind study, the COMPASS study, 3 arms, 11 100 patients in each arm. In the first arm, steroids, 250 with as a maintenance, Bricanil as a reliever. In the second, Symbicort, 329 as a maintenance, Bricanil as a reliever again, and in the third arm, Symbicort Smart, Symbicort maintenance and Symbicort reliever. Again, Symbicort Smart reduce the rate of exacerbation by 39% compared with Seretide, and by 28% compared by Symbicort again, but with short-acting as a reliever. Of course, taking Symbicort contains ICS as a maintenance and a reliever. This will be on account of using here higher doses of steroids. Is this true? No. When they compared the three arms in the COMPASS study, the steroid burden, comparing the three arms in the beclomethasone dipropionate equivalent, it is higher with the Seretide, 250/50, higher with the Symbicort with the short-acting, much more higher in the two arms than in the Symbicort Smart. Even the total number of events are higher in the first two arms, and the total day with events much higher. The last study is very similar to the previous study, and the difference here is using higher doses of Seretide to compare Symbicort Smart with Seretide. Here 550 BID with short-acting as a reliever, and again Symbicort Smart reduced the exacerbation compared with higher dose of Seretide, and the difference is statistically significant. One of the main concerns of using Symbicort Smart, you will give the canister to the patient, tell him take morning, evening, regular dose, and take in between whenever you need. The main concern is the patient will use it frequently, but on the ground, 87% of the patients, that means about 90% of the patients, did not need in between the maintenance or maximum 1 or 2 inhalation. So this is the Symbicort treatment plan. You will tell your patients you will take the medicine regularly twice a day, and when you improve, even once a day, and take it whenever you need. What about the recommendation of the expertise about this Symbicort Smart? Peter Barnes said that single inhaler therapy will revolutionize the asthma treatment, providing more effective with lower doses of inhaled steroids. This approach may become the mainstay of asthma treatment in the future. Eric Bittman said that the key point in Symbicort Smart approach is the timing of the dose. Patients will address the symptoms, not just with the use of bronchodilator in the case of reliever, but ensure that airway inflammation is addressed in every inhalation by ICS. So, the take-home message, Symbicort Smart, even when used as a reliever therapy, Symbicort Smart treats the underlying inflammation with every inhalation. Patient adjusts medication immediately at the onset of worsening by taking additional inhalation. This will improve the asthma control with the lower overall drug load, and finally increased simplicity compliance, adherence of the patient. Just one inhaler required to manage asthma, both at the maintenance and reliever. Thank you so much for your kind attention.
شكرا للاستاذ الدكتور عادل، ويعني انا بعيد الشكر له على انه اختصر لنا 10 دقايق، وان هو يعني الحقيقه كل شويه المؤتمر الصوره بتاعته بتزدهر، والحقيقه التنظيم واللجنه العلميه جايبه مواضيع ممتازه جدا. وطبعا يسعدني ان انا اقدم اخويا وصديقي الاستاذ الدكتور طارق صفوت. He will speak about update in management of COPD.
شكرا يا دكتور ابراهيم، وبرضه I'll keep on time، وان شاء الله برضه we'll save another 10 minutes يعني عشان نمشي في السكيدجول بتاعنا. COPD is a complex disease. We're all familiar with it. It has the main problem is smoking. However, some genetic factors can play a role, and at the end of the story, the patient will have an irreversible and progressive airflow limitation. ما بيقلبش يا سيد. بيقلبش. Oh, okay. It's 1990. It's the sixth top 10 killer, and in 2020 it will become the third top 10 killer. So it's really an alarming figure. The new definition it's a common preventable and treatable disease with persistent airflow limitation, which is progressive, and usually associated with an enhanced progressive associated inflammatory response in the airways and lungs. We're all familiar with that. And they added the exacerbations and comorbidities which contribute to the severity in individual patients. We're familiar with this person, and it's spot diagnosis whenever they show in your clinic. We're all familiar with the roller coasters and the fun fairs, and this is actually what happens in COPD. Everybody of us, with the evolution of age, we lose about 20 ml per year. However, in COPD, they lose more than 50 ml per year. We can control it more or less if we can stop the bad habits of shisha, happy bubbly, and smoking. And preferably, we avoid the total disability and death of the patient. We have to appreciate as well that we have two nervous system affecting the airways. We have the parasympathetic, which plays a major role, and we have the sympathetic, and this is the tone which happens if we get the low cyclic AMP, which is the sympathetic tone. We get a high sympathetic tone will cause bronchodilation. And if we get an increasing guanosine monophosphate, we get a high vagal tone. So it's a balance between the vagal tone and the sympathetic tone. We're all familiar with the triggers, and as I mentioned, the vagus has a major role in irritation of the lower airways. We have to assess the symptoms of COPD. We have to assess the degree of airflow limitation. So it's U. We have the severity, which is the FEV1. On the other vertical line, we have the risk exacerbations, and at the bottom line, the horizontal line, these are the symptoms. And concerning the FEV staging, we have 1 to 4. That's the gold. We're gonna go through it. And these are the mild, moderate, severe, and very severe. FEV1 more than 80%, 50 to 80%, that's moderate, less than 30%, that's very severe. So it's important to remember that. FEV1 is not considered the gold standard for the diagnosis and assessment of COPD. FEV1 correlates poorly with the patient-centered outcomes such as exercise tolerance, dyspnea, etc. Spirometry is essential. It's really required in our practice. So in the gold new definition 11, F2011, it's an unreliable, FE1 is an unreliable marker of the severity of breathlessness, exercise limitation, and health status impairment. This is the new classification A, B, C, and D, and it depends on a modified respiratory council, research council, and the COPD assessment tests. These will be less symptoms if we the A and the A, that's less symptoms. If you get more than 2, that's the more symptoms. The risk, if you get more than 1 exacerbation on the vertical line, it's a high risk. And if you get here as well, the FEV1 over predicted less than 50%, that's the high risk. What's the modified medical research council? That's the grade. These are the grades from 0 to 4. 4, that's you're totally breathless. You cannot leave the house. So if we're saying that you have more symptoms, that will start from 2. You on level ground, I walk slower than people of the same age because of shortness of breath, or have to stop for breath when walking at my own pace. You have to stop. So the high risk will start from 2, 3, and 4. And the COPD assessment test is a very simple test, very straightforward questions. Do you cough? Do you have phlegm? Your chest, does it feel right, tight at all? These are 8 questions and very easy. If you just put these questions and inform the patient about it, and you get more than 10, so that will be more symptoms in the curve, in these grades A, B, C, and D. That's the new classification. We have to remember the comorbidities, the cardiovascular, osteoporosis, and anxiety, infections, diabetes, and lung cancer. And these comorbidities, they influence the mortality and hospitalization. So we have to remember that morbidity is important. Lung functions are essential. It's really essential. And after, if we're saying that this patient is having COPD, after bronchodilation, his FEV1 over the FVC should be less than 70%. And according to the risk on the vertical line on the left side, we see if it's less than 50%, so this patient will be a higher risk. Inspiratory capacity is very important in the problem we face in COPD with air trapping, and the patient with COPD will have a large residual volume at the expense of his inspiratory capacity. So you more they get trapping of air, it will be at the expense of the inspiratory capacity, which will affect the dyspnea of the patient. So this is a normal person. He has a good inspiratory reserve volume. On the other hand, a patient with COPD has a lesser volume to give the power of inspiratory capacity. So he's losing a lot. And we see it with the dynamic hyperinflation. Whenever the patient performs exercise, he is unable to perform a proper exercise. هو مش محطوط ليه التايم مش محطوط. لا حط التايم مش عارف. اوكي. برضه ما بيقلبش. Okay. Dyspnea is important. It's the major symptom. So the patient will present to your clinic just because he's complaining of dyspnea. Why dyspnea happens? Because of 3 points. The hyperinflation at rest, or with exertion, that's the dynamic hyperinflation, increased ventilation demand, weak respiratory muscles. All these will lead to limitation of activity in COPD. And it's the spiral. The problem the patients have whenever they get this COPD, they don't perform exercise at all. They are reluctant, they don't endure in exercises, and that's why it's always deconditioning, and which aggravates the dyspnea. We have to push the patients with COPD that they should perform some kind of exercise so that their muscles don't get affected and get worse in their condition. So air trapping is very important, and we have to control it by whatever the medical lung volume reduction or whatever the new techniques. So this is, we're familiar with the X-ray, low flat diaphragm and hyperinflation. And it's important as well to have a lateral view to see the extent of retrosternal emphysema, which should be calculated 3, 3, and 7. So if it gets here, the cross section is more than 3 centimeters, the patient has got a retrosternal hyperinflation or emphysema. So our target in treatment, whether medical or surgical or by bronchoscopy, is to reduce or to reduce the lung volume in size, and this will affect the dyspnea and will reduce the dyspnea. We have our task as physicians to reduce symptoms and to reduce the risk. So this is our main goal in COPD management. That's the new classification of how to manage the pharmacology of therapy. And as you see here, we have first choice, alternative choice, and other possible choice. Let me go into the first choice. We use the inhaled steroids in CND. Second choice, we don't use the ICS, but you use it in the ICS, inhaled corticosteroid, only in grade D, which is the very severe one, which is less, you have an FEV1 over the predicted less than 30%. The other possible choice, you don't use steroids at all. So you have, as a key opinion leader, whatever, you're a consultant in chest, you have these different choices, either the first, second, or the third. And of course, you use all the armamentarium you have, whether short-acting, long-acting beta agonists, LAMA, the long-acting antimuscarinics, the new phosphodiesterases, etc. So the bronchodilators are really the main cornerstone of COPD treatment. Dilators are very important in our practice, and they cause this deflation by opening the airways, so you get deflation of the terminal spaces, and the alveoli get deflated, so you can get diminishing, or you get a diminished trapping of air, and the inspiratory capacity will improve. This is one of the new treatment, the Indicadrol. It's an ultra-long acting beta agonist, and its effect is through, it works for over 24 hours. It has an immediate action on the beta-2 receptors, and at the same time, it has a prolonged action through the lipid mediator when it combines with the RAFT. It works in the first 5 minutes, and after 5 minutes, and it has a prolonged action of 24 hours. And this is the salmeterol, which is as well a long-acting beta agonist, but it starts to work after 30 minutes, and it only works for 12 hours, so you need to take it twice. Seofenilin is a good anti-inflammatory, and usually we give it as a low dose, and the serum seofenilin should be less than 10 microgram per ml, and they claim that it produced some reduction in the neutrophilic content of the sputum, and so they reduce the chemotactic response and the concentration of IL-8. Exacerbations is important, as we said in the vertical line. If you get more than one exacerbation, so you're a high-risk COPDer. What's exacerbation? That you get a worsening of the patient respiratory symptoms that is beyond normal day-to-day variation, and which leads to a change in medication, or use oral steroids or whatever, inhaled steroids, and or antibiotics, or the patient needed hospitalization. This is what is meant by exacerbation. What's against steroids? The steroids, using steroids, in COPD, that's the against using steroids, that they claim that it prolongs the survival neutrophils by decreasing apoptosis, which is the programmed cell death of the neutrophils, and so they do not suppress the neutrophilic inflammation in COPD. And COPD is mainly a neutrophilic reaction on neutrophilic inflammation. Those who are with a pro-inhaled steroids, that it inhibits the cytokine synthesis, including IL-8 and TNF. It inhibits the macrophage activation. It increases synthesis of the secretory leukoproteases, and it decreases mucus secretion. So that's the debate, and it will always remain the debate with the pros and cons, and that's why the choices, we have the first, second, and alternative choice in the pharmacotherapy. Vitamin D is very important, and we have to realize the vitamin D. It's a shame that we're in a country with the sunshine, and we have a lot of patients have deficient vitamin D. Vitamin D is an immunomodulatory action, and it works very well with a patient with COPD, and it should be well calculated, and the patient shouldn't have a vitamin D. Why he has the COPD has a vitamin D deficiency? Because he is, first of all, reduction of outdoor activity. He's not exposed to sun. He's afraid to go out. Increased use of steroids. Impaired activation due to renal dysfunction. And the fourth thing is lower storage capacity in the muscle and fat due to wasting. These are the main reasons. I believe the major problem is the reduction of outdoor activity. That's why we really push the patient that we have to let them do some exercise as a rehab program. وقف تاني يا حبيبي. مش عارف تعمل ايه عشان نشتغل. زمان اوكي. So this is statins as well are a modifying agent, and they work as an anti-inflammatory and immunomodulatory. They have an immunomodulatory effect, and one of the major reasons of death of patients with COPD is cerebrovascular or cardiovascular. So statins can work as well in this area. The bad outcome in COPD is manifested by first limitation of exercise and daily activities. These are the bad outcome. If the patient goes frequent to hospitals, worsening of dyspnea and frequent exacerbations. The body index should be evaluated as well. That's the body mass, the airflow obstruction, dyspnea, and exercise capacity. These are some of the some stuff which can improve the survival in COPD. The smoking cessation program. We have to develop the anti-smoking campaign and the anti-smoking clinics, rehab, heart disease, statins, it's question mark, but it can work. New treatments and for the quality of life and air trapping. Rehab is very important, and if we see this in this paper in Kazabori in 05, that rehabilitation by itself made an improvement in endurance time per minute about 60%. If you add the long-acting anti-muscarinic, you can improve another 30%. So combining rehabilitation with the LAMA or LABA, you get an improvement in the exercise endurance of the patient. PDE4 are important. They can decrease inflammation and slow the progress of disease, and it's a debate between the PDE4s and steroids or concerning the inflammatory process which can happen with COPD. Other new treatments in the pipeline are mentioned here, but very, very expensive. Antioxidants, it's a good product, it's cheap, and we use it a lot in our practice. Non-invasive ventilation, we've been discussing this morning, and it's recommended, especially in patients who have respiratory acidemia, retention of CO2, and we can start by this before going into aggressive mechanical ventilation. Lung volume reduction surgery has been a lot concerning this surgery. It's a drastic surgery, and you remove the upper lobes, both upper lobes, provided the patient has an upper lobe emphysema, not the centrilobular generalized emphysema. So if you have an upper lobe emphysema, you can, but there has been a lot of question marks concerning this surgery. It's a very heroic surgery. We're going now through the era of endobronchial lung volume reduction with the expiratory valves, and this is one of the famous, but as well very, very expensive. I think the one will cost about 2,000 euros to implant it into and deploy it in the airways, and it's a one-way valve which allows the air to go out, not to go in. But it has its own complication like pneumonias and pneumothorax. Lung transplant is still one of the end stage management if we're considering or we have the facility for a lung transplant program. And of course, bilateral lung transplant is much better than a single lung transplant. These are my final slides, and concerns and questions will remain in all meetings. There will be always a debate concerning COPD and asthma as well. However, the take-home message that evidence-based medicine is the key message in our clinical practice. We have to rely on the evidence-based medicine, and thank you very much for your attention.
Thank you, Professor Tariq Safat, for this good session. Please.